Hi, this is Ron Kirshner, physician toxicologist at the Nebraska Regional Poison Center, and we're going to talk about toxic alcohols. So we're going to review some causes of metabolic acidosis in the suspected overdose patient, talk about the laboratory diagnosis of toxic alcohol ingestion, and talk about some of the specific agents. So what defines a toxic alcohol? About 500 years ago, this guy, one of the forefathers of modern toxicology, said poison is in everything. The dose makes it either a poison or a remedy. And really, all alcohols are toxic. People die of acute ethanol poisoning. But when we say toxic alcohol, we're really talking about the substances where the metabolite is more toxic than the parent compound. Things like ethylene glycol, methanol, diethylene glycol. So let's talk about a case we had from a few years ago. This man called the poison center to say he drank antifreeze as an ethanol substitute, asked if that was okay. We said no, got to go to the emergency department. So he had normal vital signs, routine labs were pretty normal, and really everything looked pretty good, except he did have some ethanol in the system, and that was kind of a confounding factor. Unfortunately, the ED providers dismissed him without ever calling us, and we'll come back to that. So why do you have an anion gap? The body's electrically neutral, so the number of positive ions should equal the negative ions. But the anion gap is only looking at the charged particles in the basic metabolic panel, not in the whole body. And it's not including things like phosphates and calciums and negative charges on various proteins, of which albumin is the most important. So the way to calculate anion gap properly, sodium minus the chloride and the bicarb. Some people include the potassium in there, and that can throw things off. But normally, anion gap is considered between 8 and 12. So what causes an increase in anion gap? That's usually because the bicarb, which is the main buffer in the blood, is being consumed by some acid, either an endogenous acid or the person ingested an acid or something that's metabolized to an acid, and that's consuming the bicarb. So we often see an acidosis or a low bicarb, an increased anion gap in somebody with a suspected poisoning. You can also have a non-anion gap acidosis where the bicarb goes down, but the chloride increases in a sort of compensation. And that's much less common in poisoning, so we won't really go into it. You've probably seen some variation of this kind of a mnemonic, and you can see a lot of things can cause an anion gap acidosis. All of our familiar toxic alcohols are on here, and a lot of non-toxicologic things. So a low anion gap acidosis is something that we don't see that often. There are some toxicologic causes, like a very high lithium level, where you have unmeasured positive ions. And if your albumin is very low, that can also cause a low anion gap. And you could be fooled because somebody who's malnourished might have a baseline anion gap of something like 6. And that person's anion gap of 12 might be elevated for them. That could be a confounder. So what do we care about the anion gap in the suspected overdose patient? Well, a lot of these guys are going to have an anion gap for various reasons. So they may have been agitated, or they may have had some seizures, and that may have increased their demand for ATP, which they couldn't meet, and they had a transient acidosis. They may have been hypotensive, hypoxic, And that acidosis may resolve with supportive care as the underlying cause is treated, and it may go away with supportive care. But we don't want to miss some cause of an acidosis that's not going to get better with supportive care. In other words, if it's something like a toxic alcohol ingestion, that's going to need something more. That's usually going to need some sort of specific treatment beyond just supportive care, and we don't want to miss that. So how common is toxic alcohol ingestion? Well, this is data from 2013 from a paper a few years ago. And at that time, there were about 3,300 cases toxic alcohol ingestion reported to U.S. poison centers, the great majority of them from ethylene glycol. Problem is that it's not that easy to measure toxic alcohol levels. It's done by gas chromatography, typically at a specialized reference lab, and it's a send out. You're not going to get this back in real time. So most of the time, you're going to treat based on a high index of suspicion and possibly relying on a surrogate marker. The surrogate marker that we usually use is not a very good one. Usually, we're relying on something called osmolality. Osmolality is a measure of how many particles are dissolved in solution. And anything can increase your osmolality, but most pharmaceuticals, you don't take in large enough quantities to have a measurable effect. It's only going to be alcohols that you ingest in large enough quantities. And most hospital labs can measure osmolality, and you can do a calculation to estimate what you think osmolality should be. You could measure the osmolality and then subtract what you think it should be. You can calculate that using this equation, which is really just putting everything in the same units. When you get back your labs, your chemistry, well, sodium is already in the right units. The lab typically says, here's your sodium, it's in milliequivalents per liter. So you just have to double it because every sodium is going to come with a negative ion. But the BUN glucose and ethanol are reported in milligrams per deciliter, at least in the United States. And then you've got to change that over. There's some debate as to the proper denominator for ethanol. I won't go into that in detail now. So you get that, and you come up with some number called the osmol gap. When you subtract what you calculate osmolality should be from what the lab actually measures. So you get an osmol gap. Is that it's elevated? If it's elevated, is that a toxic alcohol? Well, not necessarily. It's not that specific. Other disease states can cause osmol gap elevations. DKA, alcoholic ketoacidosis, sepsis, kidney failure. But if the osmol gap is very elevated, meaning greater than 50 milliosmoles per liter, that's almost always due to a toxic alcohol. So it's not all that specific. It's not that great a test for other reasons as well. For somewhat unclear reasons, some people at baseline can actually have a negative osmol gap, and they might have a toxic alcohol ingestion of concern and seem to have kind of a not very high osmol gap of 10 or so, but it still might be a problem. So it's just kind of a lousy test. An additional problem is these people who ingest toxic alcohols often have an altered mental status, and we're not sure about the time of ingestion. So osmol gap and anion gap are really moving in opposite directions. as they metabolize the toxic alcohol, the osmol gap is declining. But the anion gap, because it's due to the metabolites, to the acidic metabolites, it's increasing. And oftentimes, we don't know the time of ingestion, and so it's difficult to interpret the osmol and the anion gaps. So bottom line is, it's hard to interpret these numbers a lot of the time. The osmol gap is mostly useful if it's fairly high, meaning greater than 40 or 50. Ethylene glycol has kind of a complex, it's got multiple metabolites. The final metabolite, oxalic acid, is nephrotoxic. And you'll notice from this slide, which I apologize for it being kind of busy, but it also has some alternative metabolites that are less toxic to the kidney. And those are dependent on having adequate cofactors, thiamine and pyridoxine. So if you have those cofactors, you might make more hippuric acid and alpha hippuric beta ketoadipic acid. So there's some advantage to providing those cofactors. So an ethylene glycol patient is generally going to be more inebriated than somebody who drinks ethanol, because for reasons that are unclear, higher molecular weight alcohols tend to be more inebriating. As far as other lab abnormalities, the anion gap acidosis is often delayed. So depending on when we see them, the acidosis might or might not be prominent. If they present early, they might not have much of an acidosis. They might have oxalate crystals. Again, that's going to depend on the timing. They might have signs of kidney failure, but again, that's mainly going to be a late finding. Now, we are going to treat them mainly by blocking the enzymatic metabolism. But can the body still clear ethylene glycol? The good news is it can. The kidneys can still clear ethylene glycol. And this has been studied. If the kidney function is preserved, the ethylene glycol will clear with a half-life of about 15 hours. As we mentioned, the crystals are a late finding. You can sometimes see some hypoglycemia. The urine may fluoresce under an ultraviolet lamp because of the fluorescein that's added to a lot of antifreeze brands, but you can't really rely on that stuff. These are the two forms of calcium oxalate crystals. They're kind of cool if you can see them, but you can't rely on it. It's got to be a spun urine. It's a little easier to see in a polarizing microscope, but it's not absolutely necessary. So these patients with ethylene glycol poisoning may need airway management because they may be pretty obtunded. They may need a correction of acidemia with bicarb. And the main treatment, the mainstay of treatment, is going to be inhibition of metabolism, typically these days with fomepizole. Historically, it had been with ethanol, and we're often going to give them the cofactors, as we mentioned, thiamine and pyridoxine, to enhance production of less toxic metabolites. And if they're critically ill, they're often going to get dialysis, as we'll mention. Now, ethanol is not given that much anymore. They used to be on ethanol drips in the old days. It's probably hard to find intravenous ethanol formulations anymore, but it's probably good to keep a little ethanol around. Our host institution pharmacist keeps some ethanol around because it's common for antidotes to be on shortage. So you never know if fomepizole is going to be available in sufficient quantities. So your ethylene glycol patient might end up having to be treated with some ethanol given by nasogastric tube in a pinch. Fomepizole was developed in the 1980s as a more efficient inhibitor of alcohol dehydrogenase. It's easier to administer. You don't need an infusion. It's a Q12-hour drug. It just blocks that first enzymatic step, whether you're dealing with ethylene glycol or methanol. Because it's a small molecule, it's easily dialyzed. So if they're also going to get dialysis, the dosing has to be adjusted and has to be given more frequently than 12 hours. And, we can remind you of that dosing adjustment if you call the poison center. It's not a completely definitive therapy because it's just going to block the metabolism. It's not going to do anything about the toxic metabolite that you've already made or the acidemia. So dialysis can clear the toxic metabolites. It can correct the acidemia, and it can help you compensate for the renal failure, the oliguric renal failure that's developed in a late presenting ethylene glycol patient. So that patient might potentially need dialysis for some time, and typically intermittent dialysis is preferred to continuous renal replacement therapy, which is just not going to be as efficient. They might need that if they were hemodynamically unstable or something. And peritoneal dialysis is not recommended. So who's going to need, how do we know if they need dialysis? Well, generally, if the ethylene glycol patient has a pH of less than 7.25, that's an indication that they've already metabolized a significant amount, and they probably they need dialysis. They need a kidney consult. If they've already got a creatinine of greater than 2, again, that's an indication that they need nephrology. What about if their ethylene glycol levels are very high, but their kidney function is still okay? Well, those patients can, in theory, just be treated with fomepizole. It just might take a while for them to clear their ethylene glycol. There might be some medical economic reason for wanting to get dialysis rather than have them stay in the hospital for 5 or 6 days getting a very expensive drug. So with methanol, methanol as a lower molecular weight alcohol is less inebriating than ethanol. The metabolic pathway is simpler. And there, it's a different target organ. It's the retina and the CNS. Now, because acidemia is going to affect the dissociation of the toxic metabolite is formic acid. And if they become acidemic, that's going to affect the dissociation of formic acid into formate and hydrogen ion. So we don't want them to become too acidemic. These patients can benefit from being treated with bicarb. If they become too acidemic, they can get into a vicious cycle. As they become acidemic, you're going to increase the proportion of formic acid that's in the non-dissociated state, which is going to more easily enter the CNS and the retina and worsen toxicity. So there's going to be some advantage to giving the bicarb. So where do they get methanol? Most common source is automotive products, particularly windshield washer fluids, to some extent gas line antifreezes, also solvents that contain methanol. These days with the pandemic, there have been some inappropriate hand sanitizers. In the rush to get hand sanitizers out, the FDA allowed importation of some hand sanitizers that contained methanol instead of ethanol. So there still may be a few of those kicking around. How do people get toxic? Usually from ingesting this stuff, but occasionally people can get toxic through inhalation abuse of methanol-containing solvents. Not very common, but the treatment is going to be basically the same. Um, the, the therapy is going to be very similar to ethylene glycol, where we block the enzymatic metabolism through alcohol dehydrogenase inhibition with fomepizole. We also use a vitamin therapy, not pyridoxine and thiamine, but in this case, folate to enhance the metabolism of the toxic metabolite, formic acid. It's a higher dose of folate than you would use for nutritional therapy, as I've noted here. One thing that's a little bit different, you can give them fomepizole, but when you do that, what happens to the remaining methanol? Unlike ethylene glycol, methanol is not cleared very well by the kidneys. So it's cleared by the lungs, and the half-life is really long. It's 50 plus hours. So you've got to do something else if you're dealing with a significant methanol ingestion. You actually need another consultant. So if it's ethylene glycol, the kidneys can clear it, but if it's methanol you're dealing with, you need nephrology to get involved and to dialyze them. So what happened to our patients who drank the ethylene glycol as an alcohol substitute? Well, that first emergency provider kind of blew them off and said, you didn't really do anything. You're out of here. Unfortunately, didn't involve the poison center. So some hours later, family called EMS and sent him to a second ED where he was noted to be obtunded, to have a pH under 7 and anion gap over 30. And there he ended up being intubated, sent to the ICU, started on fomepizole, thiamine, pyridoxine, getting dialyzed. He had an ethylene glycol greater than 200. Methanol was undetectable. So where did they go wrong? In the first ED, of course, the biggest problem was not calling the poison center, but they didn't notice the confounding factor. This guy had partially treated himself. His ethanol was 55. So that's why he hadn't become toxic, because ethanol has a higher affinity for alcohol dehydrogenase enzyme than ethylene glycol. So sure, he drank them both, but nothing was happening until he metabolized his ethanol. And then he started to metabolize the EG, and then he got sick. So isopropyl alcohol, sometimes thought of as a toxic alcohol, but not really that toxic, mainly because the metabolite, acetone, is not really any more toxic than the parent compound. But a lot of people with alcohol use disorder know that this is your go-to substance if you can't get a hold of ethanol. It's a little more intoxicating than ethanol, and it'll get you a little more sick. It may cause some bump in your creatinine, but that's a lab artifact. It interferes with some lab assays for creatinine, but they don't really have kidney failure. The acetone goes away, and their creatinine returns to normal. Propylene glycol, found in some antifreezes, a higher molecular weight alcohol, a little more intoxicating than ethanol. It's metabolized to lactate. So what do you do with these folks? They have high lactates, but unlike a lot of patients with high lactates, they're not that sick. They have high lactates because they ingested something that's a precursor to lactate. Treatment for them, as for people with isopropyl ingestion, treatment is supportive care. So our last case is a 26-year-old man who came to our host institution. He's actually a trauma patient involved in a vehicle crash who became obtunded. There was minimal vehicle damage, but his mental status declined. And ED providers noticed that he was on some psych meds. So they did a mini overdose workup. They saw that acetaminophen, salicylate, ethanol, and valproate levels were all basically negative. They pan-CT'd him, and they found no evidence of traumatic injuries. But repeating his routine labs, they saw he's got a worsening anion gap acidosis. He was becoming pressure dependent. They were needing bicarb to maintain his pH. We suggested they do an osmolality, and he had an osmol gap of about 40. So they started him on fomepizole. They ordered some labs, sent to a reference lab, put him in the ICU, consulted nephrology, and we thought, oh, this is going to be one of the things that we talked about. But ethylene glycol and methanol were undetectable. And then his mom, who lived with him, found an empty container at home. And this is what she got. But by day 4, his mental status and his kidney function returned to normal. He admitted to a brake fluid ingestion to harm himself, but then changed his mind and got in a crash. So ethylene glycol ingestions, diethylene glycol ingestions are not that common. Most of our knowledge comes from mass outbreaks where oral medications have been contaminated with diethylene glycol that was substituted for glycerol or propylene glycol, typically an oral antibiotic. So a famous outbreak in the US occurred in the 1930s, and that led to testing of pharmaceuticals by the Food and Drug Administration. And most of the outbreaks in more modern times have been in the developing world. So in some ways, it's similar to ethylene glycol. It's been shown in animal models that diethylene glycol toxicity is from a metabolite that's responsible for the acidosis and for the kidney failure. The mechanism of neurotoxicity is less known. But we recommend if you suspect diethylene glycol, the treatment is fomepizole and nephrology consult. And we think it's more nephrotoxic than ethylene glycol. You may every now and then see unintentional toxic alcohol ingestions because people, for whatever reason, will put automotive fluids in secondary containers. They may take the antifreeze or the windshield washer fluid and put it in a juice bottle that does not have a child-resistant closure. So little Johnny may be thirsty and take this container, take a few swigs of it, and then what do you do? What do you do with that child? And sometimes it's an adult. This has been studied a number of times in the literature, and where that person has had serial labs and actual levels, and they usually turn out to have negative levels or very low levels. So our recommendation is typically to admit them overnight and get serial labs, serial BMPs for anion gaps. And we treat them with fomepizole only if they have an increasing anion gap. So some of our key points is basically we have to look at these patients on a case-by-case basis. If we have somebody with an unexplained anion gap acidosis who's really sick, we suspect a toxic alcohol ingestion, we may well end up treating them with fomepizole while a definitive test is pending. On the other hand, if we have somebody who's not particularly sick, who has kind of an intermediate anion gap, let's say in the 15 to 20 range, and we're not really sure what's going on, we often recommend doing supportive care, giving them a fluid bolus, and repeating the routine labs to see, is it improving? Are we going in the right direction? If they're sick, if they have a more severe anion gap acidosis, we're often going to recommend treatment while the definitive test toxic alcohol levels are being sent to a reference lab. They're getting treated with fomepizole and possibly a nephrology consult. Those patients with unintentional ingestions out of a secondary container, often they're being admitted for a brief overnight observation with serial labs to get a sense. Often they are going to turn out to be fine, but just to be sure they're getting their serial labs. These are my references. I want to invite you to visit our website, nebraskapoison.com, and you'll find there a link to do a very brief feedback, which we really appreciate. And I want to thank you for listening and invite you to call and tell us about your cases. Thank you again, and we hope to hear from you.